Imaging children can be very difficult. Very young children may not be able to understand and follow instructions or hold themselves still for long periods of time. Some children may be frightened and become uncooperative, making an imaging exam all but impossible without the use of sedatives. However, as CT technology has developed and scan times have gotten shorter and spatial and temporal resolution has improved, imaging children, even the very young and the very sick and the very unobliging, has become easier and more effective, making CT the tool of choice for a large variety of conditions. It is the gold tool for abdominal infectious disorders, cancer, trauma, and blood vessels. In children, CT is primarily used to evaluate an injury from trauma, particularly injuries to the brain, to diagnose abdominal pain and infectious or inflammatory disorders, to diagnose and stage cancer and monitor the child's response to treatment, and to evaluate the condition of blood vessels and the heart in children even as early as infancy. This diagnostic versatility and usefulness has, of course, led to an increased use in CT studies in children. In a collaborative effort, the American College of Radiology, the Society of Emergency Medicine, the Society of Body Computed Tomography and Magnetic Resonance, and the Society for Pediatric Radiology developed the practice parameters for the performance of pediatric computed tomography, listing indications for CT imaging and emphasizing in its introduction that CT examinations should be performed only for a valid medical reason and with the minimum exposure that provides the image quality that is necessary for adequate diagnostic information. You can read more about the practice parameter for the performance of pediatric computed tomography at the following link, which is on the www.acr.org website under Practice Parameters for CT-Pediatrics. The increased use of CT has led to a marked uptake in the radiation dose from medical imaging tests over the last 30 years, from about 0.53 millisieverts to about 3.0 millisieverts, with CT scans accounting for 50% of the per capita dose. According to the National Cancer Institute, somewhere between 5 and 9 million CT scans are performed on children each year. Research examining the percentage of emergency room visits that resulted in a pediatric CT scan between the years of 1997 and 2007 found that the percentage of CT scans ordered for children in the ER increased from 1.2 to 5.2%. However, more recent research has found while CT scan use for ER visits has increased across all age groups, its use has decreased for children since 2010, suggesting greater caution about its use due to the risks it possesses to the pediatric population. To better understand why a potential increase in caution surrounding the use of CT in children is encouraging, let's take a look at the amount of ionizing radiation a CT delivers to patients in comparison with conventional radiography. It is important to remember here that children have many more years ahead of them than adults do, and so a much greater period of time for cancers to be developed is expressed. CT scans delivered a significantly higher effective dose than conventional X-rays. By way of example, the typical chest CT will deliver a dose 100 times greater than that delivered by a typical frontal and lateral chest X-ray. The average effective dose from a CT examination usually falls between 1 and 10 millisieverts. To put that further into perspective, the lowest doses received by Japanese survivors of atomic bombs were between 5 to 20 millisieverts. Some CT procedures delivered a higher dose than others. While a head CT typically delivers a dose of 2 millisieverts, a chest CT delivers an average dose of 7 millisieverts. An abdominal CT, an average dose of 8 millisieverts, and CT angiography, an average dose of 16 millisieverts. So, what does that all come out to in terms of lifetime cancer risks? The odds of an individual developing cancer in the course of his or her lifetime is about 1 in 3. Having a CT scan poses a lifetime cancer risk of about 1 in 1,000. A study of over 11 million Australians showed an overall children who had been exposed to CT scans had 24% higher rate of cancer incidence than those who had not had CT scans performed. And in their retrospective cohort analysis, Pierce and al. Showed that children who received a brain dose from CT that was greater than or equal to 50 milligrays had 2.8 times the risk of developing brain cancer, while those children who received an active bone marrow dose greater than or equal to 30 milligrays had 3.2 times more risk of developing leukemia. The risk of these two radiation-induced cancers is more excessive for head CT, which is the most frequently performed exam in children. In this part, we will describe the effects of ionizing radiation on the molecular level, the cellular level, and the organic level. Before going further, let's ask, what is ionizing radiation? Ionizing radiation is emitted from the CT scanner as high-energy electromagnetic waves that carry enough energy to ionize or remove electrons from an atom. Radiation is the transfer of kinetic energy from one location to another. When they pass through matter X-rays produce electrically charged particles, or ions. Because of the ions produced, the process is termed ionizing radiation. And there are various consequences to this process on the different levels: the molecular, the cellular, and the tissue level. We will start with the molecular level. The molecules can be damaged by either a direct or an indirect action of ionizing radiation particles. A direct effect is when the ejected electron interacts with the DNA atom. This ionization causes a recombination with another atom, modifying the chemical structure of the DNA. Indirect effect: this takes place when the electron interacts with a water molecule that, in turn, breaks down into free radicals, which are highly reactive entities that will then chemically attack the DNA molecule. Scientists believe that the majority of radiation-induced damage is related to the second effect, the indirect effect, since the human body and its cells are essentially composed of water. However, these two actions produce the same effect. We know that DNA molecules consist of two strands that are linked together by complementary nitrogen bases, which are adenine and thymine, guanine and cytosine, and hydrogen bonds. The lesions likely to be created are the following: a single strand break, a double strand break, bases dilution or substitution, and finally, a hydrogen bond disruption. What takes place at the molecular levels affects and is observed at the cellular level. The severity of the cellular response is related to the amount of radiation and the cell's radiosensitivity. As we know, the cells are naturally repaired by specific enzymes that can repair a DNA change. However, if the absorbed energy is too large, the repair will not be complete. So then what happens? Several events may occur. Either DNA abnormalities are irrelevant to genetic coding or are repaired by enzymes. In this case, the biological effect of radiation is limited to the molecular level and the cell remains intact and survives normally. Or the cell causes its own rapid death because of lethal mutation. The irradiation is capable of activating mechanisms of self-destruction of DNA, which leads to program death, also called apoptosis. Or the DNA molecule undergoes non-lethal mutations, allowing the survival of the cell as long as it does not go into mitosis. When the cell has to duplicate its DNA, the radiation-induced lesion will block the process, and the cell will then die in mitosis. This is the concept of deferred or mitotic death. Or finally, the cell can repair itself incorrectly, but sufficiently to avoid both mitotic death and death from apoptosis. These mutated cells can be eliminated by the immune system or become different kinds of cells, possibly cancerous ones. However, the proneness of cells to radiation-induced damage is related to their radiosensitivity. At the turn of the century, two French scientists determined that cell radiosensitivity depended on three things. Those scientists developed the law of Bergoni and Trabando. If cells are highly specialized in multicellular organisms, this means they carry out a particular function, such as neurons. Their radiosensitivity is less if cells are non-specialized, such as neuroblasts. Cells which proliferate, which mean they increase in number, rapidly are more sensitive to radiation than cells which do not. Since lymphocytes live for a very short time, approximately 24 hours, they must be replaced rapidly to maintain the health of the immune system. Those are the most sensitive blood cells in the body. And cells with relatively extensive mitotic histories over the course of the cell's lifetimes are more sensitive to radiation damage than those whose histories are relatively short. Here we see very high, the high, which is the optic lens, the thyroid, mucous membranes, medium sensitivity, the glial cells, the lung, the liver, the pancreatic epithelium, and those that are lower radiosensitive, mature red blood cells, muscle cells, and mature bone and cartilage. Highly radiosensitive cells include the bone marrow cells, basal epidermis cells, the thymus cells, the lens of the eye cells, and, of course, gonad cells. Those with lower radiosensitivity include muscle, bones, nervous system tissues. It is important to note here that children are more likely to develop certain kinds of cancers. The United Nations Scientific Committee on the Effects of Atomic Radiation, or capitals UNSCEAR, found that of the 23 types of cancers they studied, children were more likely than adults to develop leukemia, brain, skin, breast, and thyroid cancers, among a few others. For the remainder of the 23 cancer types, children were shown not to have any greater sensitivity than adults. Radiation can cause immediate effects, but also long-term effects, sometimes that are years or even several generations later. At the organic level, there are two types of effects. The deterministic effects, which are caused by cell death. These include acute radiation syndromes, fetal effects, and cataracts. And the stochastic effects, which are caused by permanent DNA alteration. These include cancers and hereditary effects. Let's start with the deterministic effects, also called as non-stochastic. Deterministic effects are related directly to the dose that's received. Those responses escalate in severity with increased dose. In other words, as the dose increases, the severity of the effect increases as well. In these cases, the effect can be seen within hours, days, or weeks. There is a certain exposure dose above which symptoms appear and under which no symptoms appear. Such a dose is called the threshold, and it should never be reached with diagnostic radiation if the appropriate radiation protection mechanisms and staff exposure dose levels are put in place and controlled. However, the threshold may be exceeded as a result of imaging errors. Some examples of the deterministic effects are cataract genesis, or the development of cataracts, fibrosis, sterility, and nonspecific lifespan shortening. Again, the threshold must occur before these types of symptoms begin to appear. Stochastic effects occur by chance and consist primarily of cancers and genetic effects. This effect typically has no threshold and occurs randomly. As the dose to an individual increases, the probability that the cancer or genetic effect will occur also increases, but it does not increase in severity. Continued exposure to low doses of radiation result primarily in stochastic type, and these effects often show up years after the exposure. The latency period for solid tumors is between 10 and 40 years and 2 to 4 years for leukemia. So, radiation is a recognized carcinogen with no threshold, begins at 0 for its effects. And even if the risk is relatively small, it's not negligible.